morning, everyone. So I'm here to talk to you about sarcoma, a rare disease and a nasty disease sometimes. So I want to know who knows what it is, sarcoma.
Like bone cancer?
Yeah, it's a tumor, and it's a tumor that can come from bone, connective tissue, muscle, fat, blood vessels, and nerve. The sarcoma are divided in two types, bone sarcoma and the soft tissue sarcoma, depending where they develop in the body. 80% represent of soft tissue and 20% of bone. Both types can occur in adults and children. Sarcoma are rare cancer and they represent approximately 1% of all adult malignancy and 10-15% for the children. There's more than 100 subtypes in the sarcoma family. That's why it's very hard to find treatment for the sarcoma because it's very rare, and on top of all, there's 100 types of them, so it's not easy. That's why we need a multidisciplinary evaluation and management. Because of the rarity and the frequent need of multimodality treatment, evaluation and management should ideally be done in a center with expertise in the treatment of patients with sarcoma. In Quebec, there's 3 centers. There's one in Quebec City, there's one in Maisonneuve-Rosemont, and here at McGill. We always need pathology, surgical oncology are taking care of the abdominal sarcoma, orthopedic, plastic for the reconstruction, and there's also medical oncology and radiation oncology. And it was proven in the studies that the clinical outcomes improve with the specialized team. The risk factor for sarcoma can be history of radiation therapy for a patient that received radiation for another type of malignancy. There's also genetic disorders, patient with a family history, example neurofibromatosis and the Li-Fraumeni syndrome. This is the one that have the Harding, the 2 Harding sisters, they have the Li-Fraumeni syndrome. The chemical exposure I've never seen, and long-term swelling also, having lymphedema swelling can cause increased risk of developing a sarcoma. I've never seen those 2. So the symptoms are a painless lump or swelling, the limited range of motion, fever of unknown origin is for more bone sarcoma, fracture from no apparent cause, and some sarcoma may not cause any symptom until they compress, they grow and they compress a nerve, an organ, or muscle. The fracture of non-apparent cause, they can be just walking, going up the stairs, and they fracture their femur or the tibia just by walking. The complication of sarcoma is after the treatment, there's a high risk of development of local or systemic disease. There's also 50% of the patient, they will develop a local or distant recurrence. The risk is greater in the first 2 years. The lung metastasis is the most single frequent location of the disease recurrence. The advanced disease in the lung, the median length of survival is 12 to 15 months. So it's not long when they start to have lung mets. The follow-up are frequent for the first 2 years, and they'll go for up to 10 years at the NUHC. So we're gonna start with the bone sarcoma. When people come to emerge with a fracture and they're 40 years and older, there's most of the time they will think of another cancer, not a sarcoma, because it's mostly metastatic bony lesions that are more frequent than the sarcoma. The bone sarcoma are generally aggressive tumor, and they are associated with high morbidity and mortality. There's 3 types of bone sarcoma. The most common one, the osteosarcoma, the Ewing sarcoma, and the chondrosarcoma. The osteosarcoma, that's what the little Harding girls had. Yeah. They count for 2/3 of all bone malignancy. They're prevalent with teenagers and after 60 years old. And they affect mostly long bones, so femur, tibia, humerus. The treatment consists of chemotherapy and surgery. And if only surgery is done, the 80% of chance of developing lung mets. That's what Terry Fox had. So he died of lung mets. And the response of the neoadjuvant chemotherapy is a major prognostic factor. If the tumor contains more than 10% of the residual viable cells, the change in chemo could be beneficial. Like for Caitlin, there was like 70% of tumor that were still there, so she wasn't, for that, they could have changed her chemo, but they didn't. So this is a pathological femur fracture from an osteosarcoma. You don't need to be an orthopedic doctor to see that there's a fracture. As you can see. And this is long nets on the CT. Is that what it looks like? It's very round, the metacells from sarcoma. They're like a little pea and then they grow. This is a osteosarcoma of a 14-year-old boy. He was operated in February. He had osteosarcoma of the proximal humerus, the head of the humerus. So this is during the surgery. They're gonna do the resection, and you see the vessel and the nerve. They always tie them with a little rope, and they manipulate them like that so they don't touch them by mistake or nick them. Or so they always do that when they lift, and they lift during the surgery. This is the osteosarcoma, the proximal humerus, the head of the humerus. Then the pathologist is there in the operating room, and she will put ink all around for the margin, so they can save the margin, like grossly, they can see the margin are positive or negative. And then they cut the specimen in two. You can see the osteosarcoma here compared to the other bone is very different. Then this is the reconstruction with the proximal humerus. And then this is what the radiology, what it looks like after proximal humerus replacement.
Joanne, they reconstructed with another bone?
No.
No?
It's a prosthesis.
Okay.
Do they change the prosthesis with age, or it's the same?
No. Sometimes, like he's young, yeah, for sure he's gonna probably need more surgery down the road because they cannot lift their arm, and when they have this kind of prosthesis, they cannot go like in the back of their head. They're very limited. No? It's better than having.
You mean even long term? They remain limited?
What? It's better than having an amputation because they're still out there, and at least you can use them. The Ewing sarcoma now, we haven't had any Ewing sarcoma for a long time, so we haven't had any patient with it. There's less than 5% of the Ewing sarcoma arise in the adult age over 40, and older they are, the prognostic is not good. It's also treated with neoadjuvant chemotherapy and surgical resection. And the role of the chemotherapy in those cancers is to reduce the local tumor volume. It will facilitate the resection. There's a lot of patients, they will do the chemo just to make it smaller if they can, and they will do less damage when they do the surgery. Like there was Madame Dawson on tour, but that's a couple of years, people were not here, I don't think. She had and because she had the chemo, she was not available, and then she became available after the chemo. They also treat the metastatic disease. And then also the chemo, there's a poor response. The patient, they can benefit from radiation therapy for the Ewing sarcoma. For the osteosarcoma, it doesn't help much, but the Ewing, it does, it can help. The chondrosarcoma, we had a patient on 12, Madame Saint Marie, I don't know if you remember, it was on 12, 3 weeks ago, maybe 4. So it's a malignant bone tumor that produces chondroid matter. It's the cartilage that is affected. It's the third most common primary malignancy of bone after myeloma and osteosarcoma. For all grades and subtype of non-metastatic chondrosarcoma, surgical treatment is the only option for cure. It's radio-resistant to the radiation therapy, so sometimes we give it, but it's really not really working well for it. There's also 2 benign carcinogenous tumors that can precede chondrosarcoma, osteochondroma and onchondroma. It's often diagnosed with children, and then they just follow up with X-ray. Often it's a découverte fortuite. People have pain, they go for an X-ray, they find it. It looks like, and then they just follow it. It can transform, but not all of them. So now for the soft tissue sarcoma, it's a rare malignant tumor that arises from soft tissue anywhere in the body. So you have most thigh, buttock, and groin, upper extremity, torso, retroperitoneum is the surgical oncology taking care of them, and head and neck. ENT, sometimes they do surgery with us for that. The soft tissue sarcoma, they grow at the various rate depending of the aggressivity of the tumor. So now there's a patient on 18, Mr. Kimmerly, that he was supposed to go for radiation, and then in 2 weeks it just went through the skin, and then it was bleeding and fungated in 2 weeks, so we had to do surgery first. So it's a very aggressive cancer. The US is about 13,000 cases in 2020. In Quebec, it's about 300 a year, and in Canada, about 1,000. So there's not many patients. When you do research, you have to be many centers because they don't have enough patients to do research, and the pharmaceutical company are not interested. There's not a big pool. They invest a lot of money for not many patients. So it's very hard. We call it the maladie orpheline. So in clinical practice, all soft tissue dermal need radiation therapy before the surgery or after the surgery was done first. The surgery is the first choice of treatment for localized tumors to obtain local control of the disease. They have to remove 1 to 3 centimeters surrounding the main neoplastic mass. Since sarcoma, they produce little satellite microscope nodule, and you have to remove more, otherwise you can miss some. You have to really go in the healthy tissue. So this is a soft tissue sarcoma on a thigh. And here, the whiter it is, more aggressive it means. So just at looking at the MRI, they can tell if it's a very aggressive tumor, just with the color of the white when it's very bright. So this is a sarcoma that was removed from a thigh. They do the same thing, they do the ink, and then they cut it in two, so they see if the margin are good. So with the advance in the multidisciplinary personalized treatment of sarcoma, soft tissue sarcoma, limb sparing surgery have become the preferred choice. When I started to work, when the doctor arrived here, we were doing a lot of amputation. Now they do a lot of reconstruction. Amputation can happen depending on the situation, but it's not the first option. And the major goal of treatment are long-term survival, avoidance of local recurrence, and then maximizing the function and minimizing the morbidity.
Joanne,
right.
The amputations were not having a better survival?
No.
They were not?
No.
Okay.
No, that's why now they're doing more reconstruction. Yeah.
Okay.
So the wide excision of the soft tissue sarcoma result in a large deficit. So the reconstruction is necessary for those patients. We have many patients with big flap, and you have a big mass, and so we need a big reconstruction. The wide local excision involves excision of the sarcoma plus adequate margin of normal tissue. So the tumor is intact and it's called en bloc. But sometimes it's very hard if they're very close to a major vessel or a major nerve. Sometimes they have to leave some little cells. So then they will do radiation after for a boost. Following the resection of the small tumor, we usually have primary closure, so that's why we have a lot of Previna vac on the patient. For bigger tumor, there's a large deficit, so plasty will do the reconstruction with flap, rotational or free flap, and skin graft. Amputation is always a possibility when the sarcoma is locally advanced, or major nerve or vessel are involved, or it's a recurrent, or that is not resectable, or severe medical comorbidity. Sometimes we do it for a palliative measure, like patient is suffering a lot, so we'll do an amputation to help them. So the role of pathology is they're always in the OR with the surgeon, because the specimen, right, as soon as they remove it from the patient, they bring it to the pathologist with the suture. They know the way it was in the patient. Then if there's a margin that is identified positive, they can ask the surgeon, they can tell him where it is, and he can go and resect more. And if at the time they look and if the margin are negative, but when the tumor is analyzed, then they see that there was a positive margin, then the patient can have either another resection or a boost of radiation. We had Madame Barbouchi on 18, she had a second resection because they did the surgery and they did a piece and they said it was not good, and then when it was a final pathology, she had cancer there, so they had to redo the surgery on her.
So it's never done in the first OR when they.
It can be done if the pathologist said, oh, it's positive at this area.
They can join the OR.
Yeah, but sometimes the pathologist says everything is good, and then when the pathofinal comes, it will
like
say, oh,
a
no,
week or something for that.
That takes 2 to 3 weeks.
Yeah.
And then the patient are presented. presented again at tumor board. That's when we discuss. So the soft tissue sarcoma, they have a lot of major wound complication, as you know, people who work, it's 16 to 56%. Cellulitis and abscess, it's more, some of time we see them when they come back, the patient, they don't, often they develop it in the hospital, but wound dehiscence, seroma, hematoma, and necrosis of the muscle flap, we do see that a lot on the unit with the patient. So the issue with those wound complications is that it can delay the post-operative adjuvant therapy. Neoadjuvant means it's given before the surgery, and adjuvant it's after. It increases the risk of amputation, and it may have a detrimental impact on oncology outcomes. So like one of the Arding, she had an infection, we couldn't give her a chemo, we had to delay, but so the cancer can come back because he's not getting any treatment, so it can be very difficult. And the amputation, we had Madame Morin was on 18, she had a sarcoma, she had a reconstruction, and then she had a hip disarticulation because of infection. So we have some strategies to reduce wound complication. Gentle handling of the tissue during surgery, I don't know if they do that, the surgeon. The use of plan, I haven't asked them. The use of planned reconstructive efforts with vascular flap, this is always plasty that are involved. Meticulous attention to achieve hemostasis before the wound closure, so there is no blood that will accumulate in the area. Avoidance of closure under tension. Sometimes they have no choice, they didn't plan that they would need somebody, and then when they close it's very tense. So there was a patient in 18, Mr. Benheim, it reopened in his groin because of that.
Oh, really?
Right. It was too tense, yeah. When we removed that vac, it was all black necrosis.
Oh my gosh.
Yeah, the skin was
I remember him.
So minimizing the wound dead space using rotational or free flap, so we have to fill up that big hole, otherwise the liquid will accumulate there, the fluid, and then it can become infected at some point. If it's not reabsorbed by the body, sometimes it's too much, it takes too long. And the wound drainage with tube until the drainage is decreased, that's why the patient, they have Jackson Pratt for a long time, sometimes the big one. Yeah. Use of bulky cotton compression dressing, we don't do that now much, it's more the vac dressing we use. This is just to show you the soft tissue sarcoma, how many we have. There's so many different ones. And the one we have many cases this year, especially 18, it's all myxofibrosarcoma, and it's only 5% of them, but many patients have that one. So the liposarcoma is the most common one, but they're all different. As you can see, the number are very small, so that's why it's very hard to do to find therapy for them. So for the soft tissue sarcoma, the recurrent disease after treatment also can be a local recurrence or metastatic disease. Overall, 25% of patients will develop distant metastatic after successful treatment of the primary tumor. This is the patient you think they're gonna do the best. They did the radiation perfectly, the surgery was perfect, it was removed, the margin were all negative, everything is good, and then, oops, you find they have a long dents or something. And then, so it's not always the one that are doing, you don't think they're gonna do well that are doing well, like it depends. The one,
It's like Cassie.
right, exactly. Yeah, she was the perfect one. Another, the first Arding sister, she was perfect. She had her chemo, her surgery, her chemo, she was all following. The other one, she was all off schedule, and so far it's the other one that has issue. So 70 or 80% it goes to the lungs. And there's also other side of metastasis, skin, soft tissue, bone, liver, brain. There was a patient on 18, Madame Mercier, I don't know if you remember, she had a heart met. So the risk of developing a local recurrence, it goes with the size of the tumor. And we have many times patients that have 15 to 20 and even more than 20 centimeters, so it shows you how bad it was to get recurrence. So just tell you for the pathway at the NUHC how it works, the patient are referred to the sarcoma clinic at the Glen. Then the first visit, they will have the consult and imaging ordered. The second visit, the imaging will be reviewed and they will do the biopsy. And then the third visit, they will receive their diagnostic, and if it's a sarcoma, they will meet the radon, but depending which sarcoma it is, they will meet the medon radon team the same day. Everybody does the clinic at the same time. And then the case will be presented at tumor board. It's every Friday at 7:30. So you know what I do every Friday at 7:30. Then they will start the neoadjuvant treatment, radiation or chemo. The surgery will be after the treatment is completed, 4 to 6 weeks post-radiation therapy and 2 weeks post-chemotherapy. And when the final pathology is available, the patient will be presented at tumor board the second time. Then they will start the cancer follow-ups for every 3 months with the chest CT for the first 2 years. Then it's every 6 months for years 3, 4, 5 with the chest X-ray, and then Q year for the years 5 to 10 with the chest X-ray.
And who refers you? How do they get to you? It's a family doctor, it's.
Where it can be,
Anybody.
or other orthopedic doctor.
From another hospital.
Yeah,
from a
they
small
refer a
hospital.
lot, like to, yeah. Got other questions?
Any questions?
I remember when you said, I think it was the osteosarcoma, when they have lung mets,
Where?
their survival rate was,
But it's all sarcoma when they have long mets.
All
12 to,
sarcomas.
yeah, most of them, 12
when they
to
have
15,
lung mets, it's.
12 to 15 months.
Okay, and if they don't have, if
They
they
can-
don't have mets,
They can heal, yeah.
they
But
get,
it's
We have some patients after 10 years, they're discharged from the clinic.
and, because they're cancer-free,
Yeah.
and, if they have another cancer, it's another primary, it's another
Yeah.
cancer, it has
Right.
nothing to do with this one.
No, so
Okay.
yeah.
But it said 12 to 15 months if they only do surgery and don't have other treatment. Isn't that what it said?
No, 12 to 15 months, they have long mets, they develop.
Really?
Because it always,
I know.
because it always goes to lung?
Yeah,
Oh,
because
pretty
she's
much.
her friends are the Harding, the 2 girls, so
Oh, okay,
you don't see that.
I know, I've never, oh my god. I know.
So yeah,
Why do one of them have lung mets?
Yeah.
Yeah.
Oh, I'm sorry.
almost like the CT I showed.
But they're given.
Not as
chemotherapy,
many, but
right?
some were good.
But they're given chemotherapy for
Right.
lung mets and.
Yeah, but the response is not very good. Like her, she had mixed response, Cassandra. So some of them now, she wanted to stop chemo because she wants to go back to school and everything. So they're gonna do the one that didn't decrease in size. They're gonna do radiation. They do SBRT. So it's just for the Met, and then we'll see.
And they don't resect those,
They can resect if after a while, like they're all gone and 1 or 2 are left, they will resect, yeah. But if there's many, they won't.
And if they have the mets before the sarcoma is removed, do they still do surgery on the sarcoma?
Yeah, it depends. It could be palliative surgery, so the surgery won't be as, they won't worry as much about the margin.
Yeah.
It can be less morbid for the person,
Yeah.
but yeah, sometimes they don't do. If the patient is very sick and it's gonna be just going palliative, yeah, sometimes, yeah.
Because they don't find it in time.
No.
Yeah.
But you see, we have many patients, they have huge lump, look. Like Madame Milora, she was on 18, she had a huge one. People come with big thing,
Because they don't.
But they think it's gonna go away, that lump's gonna go away, it grows, but then they start to see that it's not going away, and then it grows fast before you know you have attention, you see a family doctor, then they refer you, they do tests, it takes a while, always a few months, so. Yeah, and they end up here with a big lump, big tumor.
Thank you. Thank you
Welcome
very much.
to you. Welcome.